So David's very kindly read out the question that hopefully by the end of this talk you might be able to answer. Wouldn't it be nice if it was as simple as innovations in technology? But maybe it's not. The real problems that happen in the NHS is that often there's not alignment with the needs, the pain, and the ability to buy a solution to resolve the needs. Procurement doesn't innovate. Clinicians face quality gaps that are varying in their reality. Management definitely face a finance gap, and the population is becoming increasingly more demanding, and they're actually starting to believe in poor care. You're a donkey. How are you going to get down without breaking your legs? Basically, these sorts of problems require system approaches. And with this sort of thing, you need quick starts, early wins, and something for everybody. And if there was evidence of what the outcome was going to be, it would help. So, I'm going to tell you what I'm going to tell you now, and then I'm going to tell you it again at the end. Basically, people that we work with in the NHS have been really successful. They've improved quality, yet they've reduced length of stay and therefore have the potential for saving money, and they've saved lives. These successes have come from individuals and communities within the NHS acting on information that we provide. And we try and provide easy-to-use tools to enable this sort of activity. So I'm now going to tell you about these successes. We focus on patient, clinician, and trust needs. So not just one narrow focus, broad focus. We look at the clinical needs, and I'll tell you about the care pathways we design in a moment. We collect data or extract it where relevant. We report and benchmark between different organisations. We support clinical appraisal and revalidation and tie that into audit. We do a behavioural change programme, and we immerse this within the commissioning and frameworks for quality. That tells you the same thing, but for those that are interested in pictures. But it also positions a few of the tools. So Assure is one of our products, Appraisal Toolkit is another, Connect, our social network, Clarity on Care, our knowledge base, and I'm going to tell you a little bit about those. In secondary care, there's very poor quality electronic records. We produce the tool that enables secondary care to create electronic records around the focus areas for the quality agenda that we're dealing with. In primary care, we extract the data, and then we create the dashboards from that extracted data. The conditions that currently we're running in secondary care are these down the left-hand side, and these are the sorts of things that we're implementing in primary care. There's more, as I'll tell you in a moment, in Clarity on Care. So the quality improvement service that we're running is currently running and has been for the last 5 years in 250 hospitals. There's currently a pilot going on in the Northwest in primary care. We've processed over 10 million patient spells. We're doing it at 250,000 per month. 11,000 are then put into quality groups, and we've collected 9.5 million clinical facts about people to enable us to do the benchmarking. And then, as you can see, lots of analysis. The basis of what we do is built on evidence-based medicine, and we write evidence-based care pathways. We've been doing this since 1998, and we have maintained 320. These were some of the first that were accredited by NICE, and NICE currently publishes these in their CKS website on the NICE site. Communities, though, are critical. Technology isn't the whole story, and what you need to do is build communities to enable people to work with the tools and the information to enable them to affect change. And so we specialise in choosing places with horrible carpets and where people can get together and talk. But also after these quarterly meetings which we run, they also can use electronic mechanisms to continue to maintain that community. And the community is maintained by ensuring that the people you're talking to, you understand who they are, through messaging, event organisation, sharing files, groups, news and forum discussions. The appraisal system's been around, which we've been doing since 2002. It does a e-portfolio, PDP, multi-source feedback, now has all sorts of revalidation inside it. The new version came out fairly recently. We also implement quality of education within the people that are implementing the tool set, and we ensure minimized administrative tasks. It's also now going into other things, so we're doing a pilot with nurses, and pharmacy is the next on the agenda. Integrating the toolkit and the quality improvement service is something that's quite important for us going forward, so that you don't have to feed the beast is feeding itself. So we've done 267,000 appraisals. 25,000 doctors have used it this year. It's in all area teams, 15 acute trusts, and as I've mentioned, these pilots, and we're working with Barnes Cumberlish on the nursing community. The dashboard for responsible officers enables you to get an overview of all the doctors and the appraisers that are working within your area, and if you want to look at an individual, you can, and it gives you a decent RAG scoring system to enable you to look at the people of interest. So let me tell you about, that's the successes, let me tell you more about the outcomes. Advancing Quality in Northwest was the first people that set about doing the quality initiative. It was led by Mike Farrow in those days. It's become Aqua, and Manchester University has been doing an independent analysis. Not surprisingly, quality programs have people that challenge it, but with decent leadership, what we've found is that people use these sorts of programs to lead quality agendas and to communicate between separate parts of maybe the trust that previously hadn't talked about the same things. So finance talking to the clinicians, etc., to enable them to achieve the goals together. And it works. So this is an aggregate score for the 8 topics. You can see it varies on the quality improvement on the aggregated scores. But across the board, there's improvement. Clearly some hospitals are better than others. And interestingly, what you see is that the gap narrows between those that perhaps still improving to those that are good. So it narrows quality, the gap. If you look at individual measures, you see a large variation in the improvement in the measures. But this is quite interesting when you look at, for example, how many people do you think would get an antibiotic when they've got pneumonia within 6 hours of hospital admission? And at the beginning the answer was, well, only 65%. And yet that's now improved. And as a consequence of these scores improving, Manchester have managed to get a New England Journal article, and what they've done is comparative analysis between the trusts that are implementing the programme and then the rest of England that are not, and have shown quite clearly improvement in mortality. They've also shown other stuff they haven't got round to publishing yet, and I'm going to give you some of our data of that in a minute. But you can see that 1.9% relative 1.9% reduction in mortality, and that's a saving of 890 lives in that period of time of that particular study. So what we can show, though, is that we can show reduction in bed days just for pneumonia. So we can show a reduction of bed days in 0.68. Might not sound so big, but some of the numbers are really big in, for example, hip and knee, where it's about 3.5 reduction. If you take a hotel cost of £250, that's a significant saving. In fact, it's 6 million in 1 year in the Northwest. But of course, that's a hotel cost, and we know what the tariff cost is. And so, work the numbers out for yourself. And this isn't just true of pneumonia. It's true across some of the other things. So this is lives saved per 1,000. This is just the Northwest. This is the bed days. This is the estimated financial saving, again, based on hotel costs. And that's what we're charging. It's a bit of a no-brainer. So, what does the customer say? Actually, I've got a nice video, but I'm not going to show it. But Mike was a customer when he set out with advancing quality. And this is the thing that he's the most proudest of. He was very nice about us, very kind of him. And actually, it's one of the saddest things that he hasn't rolled out. And this has been a consequence of the strategic health authorities disappearing. So Northwest led it, Southeast Coast came on board, and then the strategic health authorities disappeared. And we've been remiss in not actually packaging this to pitch into other structures, if actually they existed, but they're starting to exist. And maybe we ought to be talking more to individual trusts. So there's still a future though, and we're constantly trying to innovate. What we're doing with our large number of care pathways, which are all computable, is looking at long-term condition management, medicines management, risk stratification, and performance and quality measures using our knowledge bases. One in particular I'm keen to get out is medication review, which enables us to do a sort of analysis across whole populations looking for people at risk, but also identifying why they're at risk and what you can do to optimize their care in an easy to use fashion. And why is that important? That's important because 4 deaths are every hour are due to medication accident and 6.5% are hospital admissions. So if you want to do this from a cost basis, which the NHS obviously needs to at the moment, that's 1.2 billion savings by addressing this hidden problem that is pretty significant. It's more dangerous going to your GP and the rest of the health service than crossing the road. Going forward, it's important to break down boundaries. And what we're looking at are care pathways across the boundaries, which I guess we've partly heard of a potential implementation for that. Joining up of primary and secondary care data, and then looking at these risk analysis tools that are not just leaving you with a gap, but actually telling you what you can do. And this is particularly true for places like care homes, which can cause at least 10% of emergency admissions. So, to finish then, the messages I gave you at the beginning are over here, and basically I hope that I've shown you that I've evidenced it works. It develops individuals, importantly, but it also develops communities around a quality agenda, and I believe that we're still driving an innovative future. That was on the thing, and actually ours stands on this aisle, somewhere over there, and I can't remember its number, but you'll easily find us. David.
Thanks so much, Ian. Well, that's brilliant. Just a quickie, it's been mainly on hospitals, but you've got a primary care pilot, because one of the joys, if clinical commissioning is going to be what it should be about clinical transformation, is whether you can get primary and secondary care doing some of this reflective work through your technologies, isn't it?
Absolutely.
As part of a system. Seems to be an even better way forward, I'd have thought.
Yeah.
Because I think in the past, commissioners have been too adversarial and too separate from their providers. They need to be a bit separate, but not and we need to get clinicians working together on this stuff, don't we?
Yeah, you need a conversation. Yeah. And that conversation can be based around an evidence base. It starts a conversation. Yeah. It can start challenges from the conversation carries on, and eventually people agree a set of measures, maybe 5, maybe 8. But actually the effect, whilst we're measuring that effect on those measures that we've got, we observe it occurring broader than the measures that we're doing, and in other conditions on perhaps the same ward but in the same practice. The quality agenda starts occurring across the board. And the finance directors get interested too. Right.
Because when the King's Fund did that inquiry on general practice, and I'm sure it isn't applied to general practice, what they said was that they didn't think there was a reflective enough culture. And I think that's one of the issues in the health service. And you're making reflection and therefore doing something much easier, I think, isn't it?
Yes.
Yeah.
Benchmarking's the key to that, because it's so easy just to say, well, I'm doing my best. Yeah. But if you say, but they're doing better.
Yes, exactly. Mid-Staffordshire would have benefited from it. Anyway, enough from me. Any questions or comments to Ian? Will you be using this or trying to get that initiative spread to your area? Any...
I may hopefully not sound cynical, but far
Cynicism's
be it
good.
from me. The thing is that I'm a healthcare professional that contracts into the NHS and self-employed as well, so I'm looking at it from both sides of the fence. Now, just supposing when obviously you're contracting your system to the NHS, and for some strange reason, other companies get involved, and then knowing the NHS, they sort of tend to drift from company to company and system to system. How are your records transportable, and are they transportable, and the data? Because the point is that, who is actually in the scheme of things going to be legally responsible for maintaining the continuity of the data and also the protection of the data?
Okay, so set quite complex. I mean, in primary care, the data never leaves general practice. I mean, we abstract it, we pseudonymize it. So actually the data, whilst we have a copy of it, it is a copy and not the data per se. In secondary care, you're right, we do have the data, but we're a data processor for each of the trusts. And I can't tell you the level of detail relating to the legal side of things, but we are a data processor.
And also, this adds another dimension to the commissioner, because the commissioner should be for the public, whether it's private or nationalised providers. And they should be the system leader rather than trying to get into the microprocessors, which they've often done, because that should be done by the providers, it strikes me. We need to change gear as to who's doing what in our healthcare system, and these are tools that could help that system thinking, isn't it?
Yeah. It's if you want me to answer the question, it's not about the tools. It ought to be, because I'm selling you tools, but also services. But it's actually about you guys. But if you're not empowered, if you're just in silos, that's one of the problems, is silo-based data. It's getting the data broader, and we provide that service. I don't observe many other people doing what we do in the same way, so we don't really have a competitor, but there may be one, hopefully, going forward. I mean, I don't know.
So, any commissioners out there who are thinking this is great to help them with your system approach to care, or anybody? Ian, you majored because of Mike Farrer's work in Northwest SHA, as it was, and I suppose that's as much up to you. We do have structures remarkably similar. I mean, David Nicholson et al. Have managed to reinvent all the structures with different names. So there are still organizations you can work through. But I suppose some of these area teams aren't going to have that overarching thing that SHA has had, aren't they? So you're going to have to go maybe lower down to the commissioners and find them in groups, are you?
Yeah, I mean, we work with the area teams quite a lot in appraisal and revalidation, and the responsible officers have become clear. And it's clear that the area teams are responsible for the quality agenda, but I don't think that the area teams are clear themselves
that's
who
true.
they are, who internally is personally responsible. And so it's back to what I was saying at the beginning. Who is the person with the pain and the problem? It's a little abstract until it becomes like, David, I can't ring up an area team and say...
But could it be that, given that they're new, and because they're meant to be about reflection and a much more academic approach, that the academic health science networks could be your focus?
Yes.
Because they're pulling everybody together, and then you will have some names there to force the pace, and they do have a bit of money.
Yes, although they're struggling a little bit with the innovation fund to try and release it. I mean, it's just time.
But they may be the best bet as the one who has more links to the wider part of the system and yet has a reflective bent about them.
Yeah.
Anyway, if you have no more questions, as ever, please make certain you visit the stall, because I think Ian's work, I must say, I don't say this about everybody, I think is really outstanding, and it's made a difference to patients, which is key. So anyway, thank you.